حضرتك معانا، وكل الحضور قاعدين مستنيين محاضرة حضرتك. وإن شاء الله هنبدأ المحاضرة بتاعة الدكتورة رشا، الابروتش تو ذا تشايلد with precocious puberty. دكتورة رشا is a professor of endocrinology عين شمس University with the head of department of endocrinology.
ميرسي.
اتفضلي.
مساء الخير على حضراتكم. طبعا thank you very much for the kind introduction. كتير عليا الكلام الجميل ده كله، يعني ربنا يخليكي. lovely chairpersons، جمال حظي جميل، وlovely audience. الحقيقة يعني سعيدة ومتشرفة بوجودي مع حضراتكم كلكم. طبعا بشكر صديقي العزيز الأستاذ دكتور أسامة عرفة على الدعوة، يعني عزيز عليا جدا جدا. لو قعدت اقول جدا للصبح يعني حقيقي، وهو عارف كده جدا. وطبعا انا بقى بحب بورسعيد وليها مكانه كده في قلبي، اما اعرف بورسعيد بتلكك على اي حاجه عشان اجي على طول. فانا حقيقي اتشرفت بوجودي مع حضراتكم. هتكلم عن توبيك اعتقد احنا كلنا كجنرال بيدياتريشنز بقينا بنشوفه. طفل او طفله جايين وعندهم early signs of puberty، ابتدت تبقى مشكله very common وبنواجهها. هحاول اخدها من البرسبكتيف، مش هغوط قوي في الاندوكراينولوجي، هاخدها من البرسبكتيف العام بتاع الجنرال بيدياتريكس. And this is what I call precocious puberty scenarios. We all see a worried parent of a child coming with precocious puberty, having a lot of questions in mind, asking first of all the general pediatrician before going to the endocrinologist. And these are the frequently asked questions when facing a child with precocious puberty. The parents will ask, does my child have precocious puberty, or is this normal? Will it affect the final height? Could it be hiding a serious medical illness? And finally, does he or she need treatment in every case or not? And there are some critical decisions that need to be taken by the pediatrician. And I'm speaking about pediatricians, not endocrinologists yet. What is the thread between early and precocious puberty? When to refer to the pediatric endocrinologist? And finally, the most difficult question, to treat or not to treat. We all know that puberty is a transitional phase between childhood and adulthood with a lot of developmental aspects. It's not only secondary sexual characters. We have adolescent growth spurt, ability to produce gametes, psychological changes, and a lot of changes occurring, shifting from childhood to adolescence. And if we look at the spectrum of puberty, we all know precocious puberty, which is a disease, delayed puberty, which is a disease as well, and in between we have the normal pubertal range. But even what's more challenging is the early but not precocious puberty. And we see a lot of cases like this. Girls or boys coming with early signs of puberty but not precocious by definition. And there's also late but not delayed puberty, and therefore there are population differences. And that's why the definition of delayed and precocious puberty should be differentiated between Arab countries and other European countries. For example, menarche in Egypt is at the age of 11.5 to 12. In Europe, it could be up to 16. So I think we need to revise definition for each population. So there are emerging differences in the definition. The onset of puberty is affected by genetics, nutrition and body fat, general health, exercise, climate. Puberty is more accelerated in hot climate, and finally, psychological changes. So the question is, what triggers the onset of puberty? Where is the starting point or button? Simply, there is a release of the CNS inhibitory effect from the hypothalamo-pituitary gonadal axis. In order to simplify matters, in the prepubertal period, there is a lock on the hypothalamo-pituitary gonadal axis. And with the onset of puberty, there is unlocking of the inhibitory effect on the hypothalamo-pituitary gonadal axis. So when it's red, we stop, and when it's green, we proceed with puberty. And who presses the start button? What is the most important item in starting puberty? The answer is kisspeptin. Kisspeptin triggers the onset of puberty. It binds to KIS1 receptor, stimulating G signaling protein, leading to stimulation of the GnRH analog, which stimulates puberty. But how does this happen? If you look at the hypothalamo-pituitary gonadal axis, as you see here, as we said prior to puberty, there is a central neuronal inhibition on the hypothalamo-pituitary gonadal axis. And there is a negative feedback suppression of the sex steroid on the pituitary and hypothalamus. And hypothalamic gonadostat and pituitary are very sensitive to the negative feedback from steroids. So what happens with the onset of puberty? When it goes green, you can see here sensitivity of hypothalamus and pituitary to the negative feedback by sex steroid decreases. And the neuronal inhibition is removed, leading to activation of the GnRH, FSH-LH, sex steroid, leading to axis stimulation and the onset of puberty. And you can see here there are a lot of genes regulating the hypothalamo-pituitary gonadal axis, and most important is Kisspeptin gene, in addition to other genes, and we can expect that any genetic mutation could lead to precocious or delayed puberty. And here you can see the changes in testicular size, starting from 2 ml until the adult size 25. Please remember this number. The onset of puberty coincides with testicular size of 4 ml. When testicular size reaches 4, this means we are starting puberty in a boy. At this point, you can see rise in the FSH-LH testosterone and a drop in the anti-Müllerian hormone. So please remember this number, testicular size 4. And this is our Prader archidometer that we, as pediatric endocrinologists, use for assessment of testicular size in boys, starting by 1 ml, ending by 25. Again, most important to me is number 4. When we have a testicular size of 4 ml, this means the boy is starting puberty. And indeed, there is a nutrition-puberty interaction. If there is excessive fat cells, like adequate amount of fat in the presence of energy and leptin, there is stimulation of KIS1 receptor, GnRH, FSH-LH, causing pubertal development. On the other hand, if there is an energy deficit, especially in very thin girls and exercisers, ghrelin takes the upper hand, leading to suppression of the GnRH, FSH-LH, suppressing puberty. And this means that we need an adequate amount of fat for girls in order to reach menarche. So the timing of puberty is affected by the body weight. A critical body weight must be reached to achieve menarche. And that's why moderately obese girls have early menarche, and morbid obese girls and intense exercisers have delayed menarche. Now, let me ask you this very important questions that the parents ask me. Does precocious puberty affect the final height? Yes or no? Yes, definitely yes. And this is a very big yes, because we all know that a child with precocious puberty will come with tall stature, the bone age is advanced, there is early epiphyseal closure, ending by a very short final height. So they are tall children, but very short adults if we do not treat early. And there is a happy first period. Parents are very happy when girls establish menarche. But the sad news is that the girl is not going to gain height. It's only 5 centimeters, 3 to 7 centimeters after menarche at the maximum. The same with boys. Every boy is looking forward to shave his beard. But the bad news is that he's not going to gain height anymore. Again, maximum 5 centimeters after appearance of facial hair. So precocious puberty is the appearance of any secondary sexual characteristic before the age of 8 in a girl and 9 in a boy, and these are the European definitions. I think we need to have our own definition in this. The pathogenesis is either central precocious puberty, when hypothalamo-pituitary gonadal axis is activated, GnRH pulses increase, FSH-LH increase, and sex steroids increase. What about peripheral precocious puberty? The axis is not activated. It starts from the gonads or adrenals, producing high sex steroids. And this suppresses FSH-LH by feedback mechanism, and so you're going to have low FSH-LH. So please remember this golden rule. When you have a child with precocious puberty, FSH-LH are very important. If there is high FSH-LH, this is central precocious puberty. If you have low or suppressed FSH-LH, this is peripheral precocious puberty. And the sex steroid is not determining a lot because they're going to be high in both types. So we use the gonadotropins to differentiate. There are a lot of causes of precocious puberty in girls. Please remember that in girls, idiopathic central precocious puberty is the most common cause. Sometimes it's combined, and shifting of peripheral to central precocious puberty occurs with maturation of the axis. In boys, please remember organic brain lesions should be excluded because in boys, it's a tumor until proved otherwise. So this is a simple algorithm of how we deal with a case of precocious puberty. Do clinical assessment GnRH stimulation test. And by the way, this test is the gold standard test that we use to assess the pubertal status, either central or peripheral. In a male, you must do MRI brain in every case. In females, if the girl is less than 3, rapid progression, inappropriate sequence, any neurological signs, you have to do MRI. If negative, this is idiopathic. If the girl does not have these criteria, consider it idiopathic in this girl. So we do not do MRI brain in every girl, but we have to do MRI in every boy. In peripheral precocious puberty in males, do ultrasound adrenals, testes, beta subunit of HCG, 17-hydroxyprogesterone to exclude congenital adrenal hyperplasia. If all of these are normal, it's testotoxicosis or McCune-Albright. In females, you have to do ultrasound adrenals and ovaries. And the treatment is long-acting GnRH analog, and it alters the pulsatile nature of GnRH, suppressing puberty. In peripheral precocious puberty, we do not use the GnRH analog because the axis is not activated. So we treat according to the cause. Sometimes we give aromatase inhibitor, anti-estrogen, anti-androgen, and sometimes we give combinations. So the decision is sometimes not that simple, as I told you, because most of the cases are tricky and overlapping. Now, let me take you through a zoom of some cases of precocious puberty. These are real-life case scenarios, and please help me in the diagnosis and treatment of these cases. Mariam is a 3-year-old girl. She came to me with bilateral breast enlargement, 6 months. There is no history of drug intake, negative family history. Her height is normal at the median. Her BMI is normal, no hyperpigmentation, breast stage 3, normal genital appearance. Look at the GnRH test. FSH is high, LH is normal, estradiol is high, and the bone age is normal. The girl is 3 years, and the bone age is 3.3. This is not advanced. What do you think? What's your diagnosis? Very common scenario. Yes, thank you very much. This is premature thelarchy. Very, very common. Treat or wait? Who would like to treat? Thank you very much. We have to wait. We do not treat premature thelarchy. And how did we say it's premature thelarchy? The bone age is not advanced and LH is normal, so we do not treat. So premature thelarchy is isolated breast development before the age of 8 without any other signs of puberty. No pubic hair, no axillary hair. Girls have normal height, bone age, growth velocity, high FSH, normal LH, and estradiol. It's usually regressive, but Sometimes they progress to central precocious puberty, so you have to follow up. And this is what happened with the girl. She disappeared for 2 years, and she came back to me with accelerated growth. Look at the growth velocity, jumped. And the Tanner stage progressed. This is how she came to me after 2 years, before P2A1. She has pubic hair now. And when I did the GnRH test, I found high FSH, high LH, high estradiol. Now, LH is high. It's not normal like before. And look at the bone age. She's 5 years and the bone age is 8. Is it advanced? Of course. What's your diagnosis? What happened to this girl? Thank you very much. She progressed to central precocious puberty. Now, let me ask you, treat or wait? Definitely treat. We have to treat. So, some cases of premature thelarchy progress to central precocious puberty. Girls have accelerated growth, velocity, and bone age, high FSH, LH, estradiol, long-acting GnRH analog is the treatment of choice. Now, Khalid is a 4.5-year-old boy. He came to me with bilateral testicular enlargement. There is no history of drug intake. The boy developed headache, attacks of laughter without a cause. His mother is telling me he's laughing all the time, and there is no specific cause. His height is very tall. He's +2 standard deviation. No hyperpigmentation. The testis is 8 ml. Is the testis large? Yes, we said when the testis reaches 4 ml, this is a big testis. So this is a large testis. Now look at the growth chart. Very tall, +2 standard deviation. Now, based on the clinical data, do you think this is central or peripheral before doing lab? Thank you very much. This is central because when you have a large testis above 4, this means you have high FSH because it increases the proliferation of seminiferous tubule, so the testis will be large. So this is central. Now, we confirmed this by a GnRH test. FSH high, LH high, testosterone very high, and look at the bone age. Now, the boy is 4.5 years and his bone age is 7. Is it advanced? Definitely. So what's the type of precocious puberty here? Thank you very much. This is central precocious puberty. Treat or wait? Definitely. But before treating, what is the missing important investigation? Thank you very much. MRI, sella turcica. And look what we found. We found this mass. The boy has hypothalamic hamartoma, which was the cause of precocious puberty and the cause of his neurological signs. So any boy with central precocious puberty must perform MRI brain, even if asymptomatic, even if no neurological signs. Hypothalamic hamartoma is a benign hypothalamic tumor, but it's rare. It's the most common organic brain lesion causing central precocious puberty. Long-acting GnRH analog is the treatment of choice. And surgery is not indicated in such a case because it's a very sensitive area, so it's very risky to do it. And it's a benign tumor, so there's no problem to leave it. What about this cute girl? This is Fatma. She came to me at the age of 5.6 years with bilateral breast enlargement, menarche. And menarche is very respectable before the age of 8 years. History of long bone fracture twice. No history of drug intake. Her height is very tall, +2.8. And you can see clearly café au lait patches. And she's in Tanner stage 3, pubic hair P1A1. Now she has accelerated growth, +2.8. Very tall. And look at the GnRH test. What do you think of this? FSH is low, LH is low, estradiol is high, and the bone age is markedly advanced. She's 5.6, her bone age is 9.2, very advanced. What is the type of precocious puberty here? Peripheral, yes, because the FSH, LH are very low and the estradiol is high. This is peripheral precocious puberty. We did a pelvic ultrasound and we found multiple cysts in the ovary. And she had bony dysplasia, and this was the cause of the fractures in this girl. So these are the cysts. Putting these together, yes, thank you very much. McCune Albright. غالبا دينا عشان بيجي لهم هايبوفوسفاتيميك ريكتس، ها؟ تبعك برضه. شهادتك مجروحة. McCune Albright syndrome. Yes, بس common في الفيميلز أكتر. موجودة موجودة في الميلز بس أكتر في الفيميلز. حاضر اتفضل. البونة اهي بوني، بص multiple cysts بوني ديسبليجيا، وبنعالج البوني ديسبليجيا هقولها لحضراتكم حالا دلوقتي. راحت التخدير عشان كده، عشان العظم ساعات بيبداوا انا جات لي حاله بدات في العظم الاول صحيح ايوه، ما هي اصلا رير، هي رير اساسا. would you like to give here? Would you like to give a GnRH analog at this stage? هيفيدني في ايه؟ ما هو اساسا suppressed FSH و LH. So the treatment of choice is anti-estrogen or aromatase inhibitor. Aromatase is the enzyme which converts androgen to estrogen. So when you block this, estrogen will not increase anymore. And bisphosphonate increases the precipitation of calcium and phosphorus on the bone. So it treats the bony dysplasia very well. So exclude McCune Albright in any girl with premature menarche. This is very important. The classic triad is peripheral precocious puberty, fibrous dysplasia of the bone, café au lait patches. And they are treated with anti-estrogen, aromatase inhibitor, and bisphosphonate. If the girl progresses to central precocious puberty, we will add the GnRH analog. Now, what about the pubic hair, another area of precocious puberty? It's very important to differentiate between the very mild cases that do not need treatment and the serious cases that are urgent to treat. For example, physiological premature adrenarche, you're going to have mild elevation in Dahlia S and mild increase in the height and the bone age. In congenital adrenal hyperplasia, you're going to have very high 17-hydroxyprogesterone. If there is an adrenal tumor, the most important is a sky-high Dahlia S. If there is ovarian or testicular tumor, you're going to have a very high testosterone. So pubic hair is another form of precocious puberty, like this boy. This is Ziad. He's a 5-year-old boy. He came to me with large penis, pubic hair since 7 months. He has recurrent painful erection. He's very tall, plus 2.9. Blood pressure is normal. The penile length is very large, 8.5, and the testicular size is 3 ml. Is this a large testis? No, this is not a large testis. So, is this central or peripheral precocious puberty? The testis is less than 4 ml. This is peripheral. Thank you very much. We said if testicular size is 4 or more, this means we have a high FSH. So this is peripheral. And look at the GnRH stimulation test. Low FSH, low LH, very high testosterone, markedly advanced bone age. The bone age is 11 and a half and the boy is 5. Central or peripheral? Peripheral, thank you very much. Okay. And the rest of the adrenal androgens were normal and abdominal ultrasound is normal. What else is missing in this boy? What is the investigation that the pediatrician was supposed to do and did not do in this boy? Radiological. جنبها بقى. Scrotal ultrasound. And although the boy did not have a clinically felt mass, scrotal ultrasound revealed a mass in the left testis. And this was confirmed by CT scan. It was a large testicular tumor. And the boy was referred for complete tumor resection. And this was proved to be left testicular Leydig cell adenoma, which is a serious testicular tumor. And in this boy, let me tell you, I did a very good testicular examination and there was no mass felt. So, remember that because small testicular masses may not be felt, any boy with peripheral precocious puberty must do a testicular ultrasound, even if you're not feeling a mass. Leydig cell tumor is not common, but should be thought of. Central precocious puberty can develop after removing the tumor. But at this stage, we removed the tumor and the boy was put on anti-androgens and he's doing very well. Now, this is my last case, Jude. She's 1.5-year-old Tunisian female. She came to me from Tunisia. She developed pubic hair at the age of 6 months, very early. And they kept telling her in Tunisia, this is normal, don't worry, nothing to think about. But the mother was very clever. And she insisted to find a diagnosis. She came to me, the girl was normal height, slightly cushingoid. You can see here pubic hair stage 3 to 4, clitoromegaly. The clitoris is large. We did FSH-LH, it's very low. This is peripheral precocious puberty. Testosterone is high. Dahlia S was sky high. Dahlia S means adrenals. When we have a high Dahlia S, this is adrenals. The cortisol AM and PM was highish, so there is loss of circadian rhythm, and ACTH was suppressed. 17-hydroxyprogesterone was normal. This means it's not congenital adrenal hyperplasia. And the bone age, not much advanced, meaning that it's not long time ago. What's the urgent investigation? Yes, very important to do an abdominal ultrasound. And look what we found. Right adrenal mass measuring 5 times 5. She was referred to the pediatric surgeon and she was found to have right adrenocortical carcinoma, which is common at this age. Look what if the mother followed the advice of the doctors in Tunisia to leave her alone and that she's fine and she's doing well. Precocious puberty could be very serious, more than we could imagine. So with early onset puberty, exclude congenital adrenal hyperplasia and adrenal tumors. High 17-hydroxyprogesterone suggests congenital adrenal hyperplasia. High Dahlia S suggests adrenal tumors, especially carcinoma. It's a simple test, but it will diagnose the case. So I think we've seen together there's a very wide spectrum of cases of precocious puberty. Sometimes it's just early puberty, and sometimes it's incomplete, like thelarchy or premature adrenarchy. Sometimes it's central, sometimes peripheral. The first 2 cases do not need treatment. It's a physiological condition, and we do not need to do anything, just reassure, follow up. دقيقة واحدة أقل من دقيقة. Sometimes incomplete cases like premature thelarchy progress to central precocious, and peripheral could progress to central precocious. And my final conclusion here is that puberty is a really complex process. It's not that simple as we might think. And cases do not come straightforward. There are a lot of stories to tell when it comes to puberty. It's not simple. It's really complicated. And I believe hormones have got a magical effect. And look what puberty does. I think hormones have got a magical effect. Yes, hormones play a lot. And it's nice to know how to play with the hormones. This is even better, huh? So, and since it's really difficult to deal with our healthy teens, واللي عنده teenager وجرب دماغ التeenagers, it's really difficult. احنا بنعرف ان ده داخل في البيوبرتي من psychological changes اللي بتحصل لهم. Hormones do a lot. What if there's a pubertal problem in a child? It's even worse. And I think they could drive the parent and the doctor crazy. It's really difficult to deal with those children. But I think that the state of the art is to ask ourselves what lies behind the wall of precocious puberty. We need to break the wall behind precocious puberty. Don't take it easy. It's not just secondary sexual character in a child. Serious problems could be hiding behind this problem. And we need to answer this question very clearly. Which way shall we go? Is it the pathological type that needs urgent treatment, like tumors and serious illnesses? Or is it the simple precocious puberty, which does not need anything except follow-up? We need to answer this question. It's very, very important. Sometimes there is a spectrum between both when we need to decide. I think we need to answer this clearly to be able to take the challenge and win the challenge of diagnosing and treating those really, really difficult cases. وحقيقي بقى أنا بختم بالصورة دي، بموت في الصورة دي، بحبها قوي قوي، بنزلها في كل مناسبة، يعني I'm really feeling at home. عمداء بورسعيد الثلاثة العزاز على قلبي جدا جدا جدا، بفتخر دايما إن أنا أجي بورسعيد وبتلكك زي ما قلت إنهم يعزموني وأجي و thank you for the great hospitality. Thank you very much.
كل الشكر والتقدير لأستاذتنا